class, Understanding Agitation in Alzheimer's Disease. And our presenter, again, is from Alzheimer's Orange County. And we are joined by the wonderful and amazing Kim Bailey, who has her master's degree in gerontology, and she's worked in the field of gerontology as a lecturer and aging expert for 30 years. She again holds a master's degree in gerontology and a BA in sociology, both from Cal State University Fullerton. And Ms. Bailey is the program and education specialist at the Alzheimer's Orange County, um, where Ms. Bailey is responsible for developing and presenting programs and education for families and professionals throughout the community. Ms. Bailey has a long history of academic, corporate, and nonprofit experience. So again, we are joined by the wonderful Kim Bailey. Always excited to have you with us, Kim, and I will go ahead and turn it over to you.
Okay. Thank you so much for that warm welcome. And I just want to share with all of you that we're thrilled to be collaborating with the Caregiver Resource Center. And in fact, have been partners with them over the many years of both of our organizations. And I admire everything that they do. And a lot of our families have benefited by receiving services from both organizations, which I think is really helpful. And I particularly want to call out the respite benefit because that is something that we're not able to do here at ALS OC. We're able to make referrals to respite providers, but the funding very often comes from Caregiver Resource Center. And so I think that's just wonderful. And it's always nice to see you, Rachel. And with all that said, I'll go ahead and share my slides. Oops, it looks like I'm at the end of the road here. Okay. All right. So we're here to talk about agitation and dementia today. And man, this is a challenging topic. And so I'm glad we're all here and I'm glad we're together. And this is not about doing things perfectly. This is about me talking about various strategies and tools that, hopefully will give you more confidence in dealing with these challenging situations, but no one's looking for perfection here. We're just looking to improve the quality of life for the folks we're caring for, and by extension, us, right? So we'll talk about agitation today, what it means, why it happens, and what you can do. And hopefully at the end of the day, you'll feel a little bit more prepared and not so alone in all this. So let's start here. So yeah, agitation is one of the hardest parts of caregiving. It can feel confusing, exhausting, and personal. We take the behaviors that we're observing personally. You're not alone, and just remember this is not your fault. So, just a few ground rules for today. This is a safe space and it's a judgment-free zone. And so, as I just indicated, it's just important for you to recognize that there are no perfect responses. There are no magic bullets when it comes to dementia care. Every situation is unique and people react differently. So, let's go ahead and be interactive today. And I'd like you to share with me maybe some situations that you're having. Um, and just remember that we're all in this together and it's normal to feel confused and emotional when talking about these topics. And it's just emotional in general being a caregiver. So together we're going to support one another as we navigate these challenges and look for some tools to help lighten our load. So there's a couple of strategies that we'll talk about, and hopefully you'll, at the end of the day, have a better understanding of agitation, and maybe even look at some step-by-step processes and even actual words that you can say in difficult moments. So, we're also going to ask you to build upon your own personalized plan because what works for one person doesn't work for everyone. And so, we're going to personalize the things that we learned today and put them together for a nice plan for the future. So, What kinds of situations are you struggling with now? Would anyone like to share? Debbie.
My biggest one right now is I can't tell if he's just pressing my buttons or if he's really incapable of doing something. Because I know he's
Okay.
capable of doing some things, but I can't tell the difference.
Right. And he has dementia?
Yeah, yes.
Okay. So I think one of the biggest lessons for us in all this is that they're not doing this on purpose. And I know that's kind of hard to take in because perhaps there were some behaviors before they had dementia. I mean, I can't know everybody's history, but I can tell you with certainty that when a person has Alzheimer's disease, they're not capable of of coming up with behaviors that are just there to annoy you. So it's the first thing you need to work on is not taking it personally. Does that make sense, Debbie?
It
If-
it does. It does. Except some of the behaviors were before this was going on, and
And that does
that's
make it
why
more
that
difficult.
confuses. Yeah, that's why it confuses me because it's like a pass.
Right.
It's like a pass for bad behavior. So yeah, maybe
Yeah. Yeah. Well, the thing
try
about these
harder.
diseases is that sometimes they start years before.
Hmm.
So, I'm thinking of an extreme case, but I had a client whose husband had FTD, frontal temporal lobe dementia, but she didn't know it. He had such a pattern of behavior that she divorced him. And then she later returned to him when she found out that he had a medical condition that was actually responsible for some of the bizarre behavior she was seeing. So that's kind of an extreme example. But I guess the takeaway here is that if they had the ability to reason and figure this all out and plot and plan this behavior, they wouldn't have this diagnosis. And so we have to find a way to somehow forgive them 100% of the time. Now, that doesn't mean we're going to let them hit us or do something violent, but it does mean that we're going to develop this understanding that this person is not in their right mind and they're not able to discern which is what is appropriate behavior and what is not. So
Okay.
I'm just going to kind of leave it there. I don't know.
Okay.
I know it's hard. Yeah.
Thank you.
Yeah. Yeah. If you can just sort of tell yourself, try not to take it personally and tell yourself it's not their fault and they're not doing this on purpose. It's a manifestation of their illness. Okay.
Okay. Thank you.
And I'll be thinking of you. Any others who have any challenging situations they want to bring up.
There's a few things in the chat, Kim, and
Okay.
Gladys says, my mom is 85 years old with advanced dementia, and sometimes she doesn't want to get out of bed, eat or drink, or take her medication. And then we
Hmm.
have another comment that said, my dad gets upset with me when I don't understand what he's trying to say, or if I can't
Right.
come up with the word or name that he can't remember. He will yell at
Okay.
me and say, oh, you just don't want to tell me, like as if I'm keeping
Okay.
it from him on purpose.
Okay. So, starting with that first one, there we're talking about sort of classic resistance, and it's a very common behavior in dementia care where the person doesn't want to initiate anything, they don't want to do anything. Actually, they've lost the ability to initiate activities. I usually describe it as having lost their starter button. So they really are relying on us to try and prompt them to do things. But even when we do that, sometimes they don't want to do it. And how old is mom?
85.
Okay. So there's a part of me that wants to say let her be, to some extent, because people do have autonomy. And, if she doesn't feel like initiating any activities on certain days, then, perhaps that's okay. But we always want to encourage people to get up and go, we help them with their activities of daily living. We try to plan some fun activities for them, etc. So we keep trying. But if you push, if you if you insist, they'll resist. That's sort of a rule of thumb. And if you don't insist, they won't resist. So kind of keep those words in mind. And then the second piece is about communication, which is very, very disheartening to people who are really frustrated trying to get those words out. They're not only having difficulty expressing language, but they're having difficulty interpreting it. So everything has to slow way down. And if he's asking for help, then filling in the blanks is a kindness that you can extend to him. Some people don't like that. They feel frustrated when people try to help, but it seems to me like he is asking for help. Is that the case? And you just go very slowly and you just let them know they're looking for reassurance. He's getting frustrated because he can't think of the words, and you're there and you tell them over and over again, I'm here, I'm going to help you.
So that was my question.
Hmm.
It is the case that he's asking for help. However, I don't know the answers because it's stuff from like his childhood and people that he knew that I never knew. And so
Sure.
he thinks that I should know. It's like information that anybody would know. And
Right.
I don't know the answers.
Right. So you can kind of flip the tables on him and say, tell me about that. Tell me what you remember about that.
Okay.
And if there's other family members you can consult with, that would be good too. But when all else fails, there's a powerful tool to use, and that's called redirection or distraction. And so if there are particular activities that he really enjoys, or maybe there's a food that he really enjoys, if you see him starting to get frustrated, you're going to intervene. First, you're going to reassure and let him know that you're there and that you're there to help. But then before he starts getting too frustrated, you want to intervene skillfully with something that redirects his attention. And it's not impossible to do in this disease because they really do have trouble focusing on more than one thing at a time. And so, if it were me, you could offer me pizza and I would just forget all about that other thing I was worried about. Right? I mean, you have to this is about person-centered care. It's about knowing your loved one, knowing what they like, and intervening at those times. I hope that's helpful.
Thank you.
Yeah, of course. Of course. I mean, I think when we talk about all these things, we can kind of feel validated, right? And like I said from the get-go, there's not always an easy solve for everything. Um, But just being able to talk it over, I think, is helpful. And that's why support groups are so valuable. And I know that there are many available through Caregiver Resource Center. And we have a number of groups as well. So, really, I think when caregivers work together to solve some of these things, it's good because getting more than one person's opinion is helpful. When you're sitting in a circle with your peers and they all have different ideas and strategies that they've tried, I think that can be very, very helpful. So I do suggest support groups. So, yeah, I think one of the biggest shifts we can make as caregivers, and we're already working on that right now, is trying to move away from why are they doing this to me? Or what are they trying to tell me? And that's just as discussed, very, very difficult. But when we are able to move in a different direction, it moves us from reacting to responding in a way that's more effective. So let's talk a little bit about the different types of agitation. And we've got some great images here. So, restlessness, that includes things like pacing, rocking, jumpiness, um, irritability, shakiness, repetitive movements, all of that, hoarding. So, I know I was a caregiver for a long time, and my person who I cared for would go into every room of the house and start rummaging through drawers, just and was very persistent about that. And I know a lot of the folks we've worked with here will report this type of behavior, especially the pacing. So, And then there's verbal agitation or even aggression that involves yelling, screaming, swearing, complaining. Maybe you're seeing behaviors that were so different than what you were used to with your loved one. Inappropriate, strange noises, emotional outbursts, all of that. And then it goes to the extreme in some cases when we see people lashing out, hitting, biting, kicking, hurting themselves or others, etc. So, or it could be other physical behaviors such as spitting or physical sexual advances and all of that. So, it comes in many forms. And what we're kind of here to think about is how can we get to the underlying reason or reasons for the behaviors that we're seeing. So just learning a little bit more about them might help us to tease that out. And sometimes it varies depending on their diagnosis as well. So we know that if we're trying to sort of get at why people are displaying these behaviors in Alzheimer's disease, it's often because there's such a high level of confusion in Alzheimer's disease, particularly as the person progresses. So a lot of it is just kind of fear-based. But with Lewy body dementia, you might see a different type of agitation. You might see hallucinations because that's a major characteristic of Lewy body dementia. People often have, they see people or animals, they have persistent, ongoing hallucinations. And so that causes trauma and agitation. Frontal temporal is probably one of the worst illnesses or diagnoses for agitation and just terrible behaviors. Um, and that's because there's no impulse control. People are very disinhibited in this illness. And so they'll do things impulsively, like, walk outside with their clothes off, or make a sexual advance to someone, or urinate in a water fountain. Again, these are all behaviors that are a consequence of their diagnosis. The damage in the brain for frontal temporal is different than the damage you see with Alzheimer's disease or Lewy body. And so it's affecting the areas of the brain that are responsible for personality and behavior, etc. And so you're going to see some very unlikely behaviors. And again, they're not that person's fault. They're a manifestation of their illness. And then I think with vascular, the behaviors maybe stem from just frustration because they've got this kind of cognitive variability. So it's sort of you've heard it described as a stepwise progression where people are on a plateau and doing very well, and then all of a sudden they plummet again, and then they even out again. So that variability is going to cause some problem behaviors as well. So most of the time, we can think of behaviors as a way that they're trying to get a message across to us. So, much of what we're talking about today is around, what there's some kind of unmet need. They're not just doing this to make you angry. They're trying to deliver a message and they're having difficulty with communication. So think of agitation as not just being something random that's happening, but it's purposeful and it's a way that they are trying to communicate with you because they've lost the words. They no longer have the words. So if we think of it in that light, then we can sort of tease out what it is that they're trying to communicate with us. So, and one of the things that I look for first is there something medical wrong? And particularly when you see an abrupt change in behavior, like acute agitation that's out of kind of coming out from nowhere. I always think that might be a signal that there's some type of a medical problem. And does anybody know like what kind of medical problem it might be? Can you share with me? Any thoughts about that? So you're taking care of someone and all of a sudden they start acting out and you don't know what's wrong. One of the number one things can be bladder infections. So the elderly population, and particularly those with dementia, are at risk, high risk for urinary tract infections or other types of infections. It could be a chest infection. So, sometimes when you see that abrupt change in behavior, it's they're signaling to you that there's something wrong medically. And it's hard to believe, isn't it? Because when we have a bladder infection or something wrong in our bodies, we act on that right away and we act on it appropriately. We see a doctor or we share our symptoms with someone and they encourage us to go. They're not able to do that in the case of folks with dementia. They're just not able to do it. So it's their way of communicating that need to us is through acting out. Um, so what else? Sometimes they're scared. Sometimes they're confused. Sometimes they're overwhelmed. So again, they've lost the ability to express that to us, and it comes out in a behavior instead. So once we sort of tease out where is this behavior coming from? Once we can sort of get at the underlying meaning, we can figure out the best way to intervene, right? So when you're seeing it happening, check for pain or discomfort. And it's not just bladder infections. That was one example. I mean, it could be anything. It could be a headache. It could be that they have a zipper pinching them. Um, it could be their clothes are too tight. They could have a backache. They could have an injury that they're not able to articulate. So you want to check, for physical discomfort. Another big um, issue is the environment. So we see people become very agitated when there's excess noise, when there's a problem with the lighting, all of that. The environment is something, that is often the culprit in problem behaviors. And if you've been in any of my classes before, you've probably heard the story that I tell of the person I cared for who started hallucinating in the late afternoon because she was looking out the windows and she was telling me that she was seeing people out there and that she was frightened. And so, what do you think the intervention could be there? Anybody have an idea?
Yes. The Ring cameras.
Oh, yes, absolutely. The Ring camera is good. But you know what? I didn't even know about Ring cameras when this was happening. I just closed the curtains.
Ah.
So, I mean, it was kind of a simple fix in the
Mhm.
environment. And I realized that she was sundowning. Does everybody know what sundown syndrome is? It's when the light starts to change in the late afternoon, early evening, and people start to get restless and agitated. So I started to plan for that once I recognized that this was a problem. And I would lower the blind or close the curtains. I would put on kind of soft lighting and I'd put some nice music on. And I'd say, we're going to have a little happy hour. And then I'd make her a little mocktail and a little appetizer. And we were having this very pleasant interlude every day instead of her being frightened and agitated and thinking that she was seeing people in the bushes. So this is one of the ones that you can fix sometimes. So we'll talk more about that. Communication. Sometimes we're talking too fast and we need to slow down. Remember what I said about how they're having difficulty not only expressing language, we need to give them extra time to process what we're saying. So we don't want to be speaking too fast and having one sentence run into another. We want to really slow down and explain things simply and calmly. Sometimes they are agitated because of overstimulation. There's been just too much going on in the environment, maybe. Maybe the schedule's been too overwhelming for them on a particular occasion. And maybe they've been to the doctor and then you went to lunch and now they're back and they're tired. I can remember bringing my person home and she would even think sometimes this is not my house. So, and that was the part of the day when she was very tired. So sometimes that overstimulation or fatigue can lend itself to some pretty significant behaviors. So I think that this slide really provides us with a checklist. So this is a key takeaway for the talk today, that when you see a behavior happening, you can do your quick assessment and say, is this fear-based? If so, then I'm going to reassure and comfort. If it's confusion, I'm going to try to bring down that confusion by offering maybe a nice treat, something they enjoy. If it's pain, we're going to address that and make sure that gets taken care of. And that's just sort of a way of operating your way through, seeing these behaviors. You have to be a private detective. You have to ask yourself, there's a reason for this behavior. What is it? Let's get underneath it and see if we can come up with whatever this unmet need is. Does everybody feel like they can do that? Like I said in the beginning, you do not have to be perfect at this. You don't have to be perfect. In fact, it's impossible. So lower the bar if you're really thinking that you should be perfect at all this. And just, when you try your best to come up with these solutions, um, you're doing the best you can, and that is fine. That's perfect. So, okay. So let's just practice this a little bit. Because, what we're really talking about are triggers, right? Like what were they? They were fear, confusion, pain, environment, etc. So, let me give you a scenario. Maria's helping her husband Robert get ready for a doctor's appointment. She reminds him several times that they need to leave soon. Robert begins pacing, asking, "Where are we going?" over and over. When Maria tries to help him put on his jacket, he pulls away and says, "Leave me alone." So, what do you think the trigger could be here? Or just tell me what you notice. What are your thoughts about this scenario? Maybe someone we haven't heard from yet. What's going on here?
I'm gonna guess fear. The
Okay,
fear of the unknown, and yeah, they don't remember. I mean, it could be confusion, I guess, because they don't know where they're going as well.
right.
But I did have
Or
kind of a similar thing happen to me
really?
this week on this, yeah.
Okay.
I did the wrong thing, I'll tell you that.
Well, no, no, no. Tell me what happened.
Oh, I definitely learned. I arrived at my mom's house. It was about noon. She was still in bed, and I guess she had a bad dream. And I came in the house, and I was the first one she encountered because she was still sitting on the bed. And um, I said something about, her dog was barking. I said, "Can I go feed him?" Because he was on the bed. I was going to take him off the bed, and she said, "No,
Yeah.
no." Well, later she told me that she had had a dream that somebody was taking her dog.
Oh gosh. Yeah.
So I, I learned, so I'm glad that you're
Well, and
here. But yeah,
unfortunately, you were just in the wrong place at the wrong time. You couldn't help that. I mean, you walked
yeah,
right into her just trying to clear her
yeah,
head from having a bad nightmare about her beloved dog. And then you
yeah,
said, I'm going to take the dog to feed them. So,
yeah, yeah,
yeah,
yeah.
so
It wasn't
these
good.
things happen, and I'm sure that you were able to calm her when she saw that you didn't have any bad intentions. You were just there to help.
It
And
actually got worse. I
oh, did
left.
it? Oh, you did.
I did
Okay.
leave. I called her later.
Well, sometimes
I
you need
was
to.
yeah, I don't know if I would have been able to handle it well, but now I'm more prepared.
Okay.
So
So so in this case it did escalate.
it did
But
escalate.
it wasn't her fault. It wasn't your fault. These things just
No.
happen. And
Hmm.
sometimes the best thing you can do is to step back for just a little
Yeah.
bit, So don't ever beat yourself up
Yeah.
about these things. And I'll tell you another thing. There is a silver lining in all this because for many people they may have a reaction but then they forget that they had that reaction and so they're just going to
Yeah.
move on through the day and you're left feeling hurt and disappointed but the good thing is that which is unfortunate but the good thing is they're okay they
She was okay. Yeah.
yeah, yeah, yeah. So you know what? I've been like working in this field for 30 years and I made so many mistakes when I was a caregiver. And I'll never forget one day when I walked
Mhm.
in to the living room from the kitchen and heard her talking on the phone to her daughter. And she told her daughter that she hadn't eaten all day and that she felt dizzy. And I was like, what?
Mhm.
I said, we had pancakes for breakfast, and then I made you a fruit cup for a snack, and now getting ready to have tuna salad. I went on this long kind of rambling discourse, and I realized that it was kind of like an out of body experience. I realized that this was just not the way to handle it at all, and not the way I teach people to handle things. So, I felt like that was
Yeah.
a real caregiver fail on my part. And there's something simple I could have done to address
Hmm.
that when she said that she hadn't eaten and was dizzy. I could have
Yeah.
just said, well, let me get you something to eat.
Yeah.
And then,
Much better.
right, much better. So
Uh,
we're not perfect. I keep
yeah.
stressing that, even
Yeah.
those of us who consider ourselves to be professionals, because we're human and we're going to make mistakes. But as I said, the silver lining is that they get over it. So
Okay.
they do move past it.
Hmm.
So in looking at this situation, what do you think, Tanya? I'm going to stay with you for a minute, Tanya. What do you
Well,
think of what's happening with Robert then?
my guess is fear and
You
or
said fear.
confusion. Yeah.
He
Yeah.
may not know where he's going or why he's going there. He
Mhm.
feels like there's nothing wrong with him. So why am I going to a doctor?
Yeah.
Yes. And then, of course, there was that moment in time when she goes to physically touch him and help him with his jacket. And he was startled by that, wasn't he? And it was kind of like when
Mhm.
your mother thought that you were going to take the dog away from her. It was
Mhm.
that moment where things went south. So, leave me alone. So she needed to do that, right? Just to step back for a minute, let the
Mhm.
situation calm down, and then maybe redirect him, right?
Yeah. Yeah.
Yeah.
That's good. Thank
Yeah.
you.
Sure. But you're right. It's about fear and it's about confusion. So we can also think about how we feel when we feel that way, right? And how we want people to respond to us. What about this one? I'll take you off the hot seat, Tanya, and ask someone else. James becomes upset every evening around 5. He walks from room to room, asks where his wife is, and becomes irritated when his daughter tells him she passed away years ago. So what's going on in this scenario? What are you noticing or what are some of the pitfalls of the way this was handled? Anybody want to jump in?
Yes.
Thank
Um,
you, Crystal.
you're welcome. I have a similar issue sometimes with my mom, and part of it is that her timeline is off. It's it's
Right.
it's mixed up. So things that, yes, that they have ingrained in their brain already from a long time ago stays there and sometimes comes back up as if it's that day.
Right. And do you notice that that can happen at 5 o'clock?
Yes.
And why is that, do you think? Is
Uh, Dad, I couldn't say I'm not the primary caregiver, but I have seen it close to sundowning, I guess, in early
it's
afternoon.
sundowning? They're sundowning. And 5 o'clock, 5 p.m. is a significant time for most of us throughout our life, right? I mean, at 5 o'clock, people are getting off work. Maybe they're going to pick up people from school. Maybe they're going to the store, so there's a lot of movement going on around 5 o'clock. And I
Mhm.
know that when I first started working in the field, I was in memory care. And I used to just look around at 5 o'clock, and men were like searching their pockets for their keys because they felt like they needed to go somewhere. Women were, hanging around at the door and saying, I have to leave. I have to pick up the kids. So I think you said it, Crystal, perfectly. It's kind of ingrained in people. But what happens is because they have Alzheimer's or some type of dementia, they can't remember where it is they're supposed to go or what they're supposed to do, but they just have that feeling that they're supposed to be doing something. So sometimes they articulate it and sometimes they don't. But James is a classic example of someone who's sundowning, right?
Mhm.
So what about the other piece of this? What about the wife and how that was handled? Anybody have any thoughts about that? Okay, so if someone has dementia and their wife has passed away, do they always remember that? No, no.
He's learning that she's dead every time the daughter tells him.
And reacting as anyone would when they're actually like quote unquote hearing the news for the first time. So it is like they're hearing it for the first time. So in this scenario, he's becoming irritated, but for a lot of people, they would actually like become grief-stricken even. So that's another trigger that we can influence because we can distract them from thinking about that by saying, well, I mean, we can validate them. We can say, oh, you're thinking about your wife. Let's go look at some pictures of her, or tell me about your wife. I mean, there's a way to validate things without telling the whole truth. And we don't even really recommend that. We talk about, some creative therapeutic fibbing. If we know it's going to upset them to know that their loved one has died, then we're not going to tell them. We're just we're going to distract them if they want it. My person who I cared for wanted to call her husband at night. She knew during the day that he had passed away, but at night she'd get super confused and she'd want to call him. And I'd say, "Oh yeah, we can call him. We'll call him in the morning. He's sleeping now." So you don't want to say no, to people with dementia. You want to figure out a way to avoid that because they can get super frustrated. But there's usually a workaround that we can figure out. So, any other thoughts about that? Okay. So, again, as I've said several times already, agitation rarely comes out of nowhere. There are usually some early warning signs that we need to be sensitive to. What we see a lot are people plucking at their clothes or fidgeting. Maybe they're starting to have some increased movement. They may start repeating questions over and over again. Um, you may see shifts in their moods, etc. So these are all like precursors to a potential behavior change. And so this is where we want to use our skill and skillfully intervene. So we don't want to wait until things escalate. That is really critical. So this is just a simple, escalation model. Over here on green means everything is fine, but you're starting to maybe see some signs as you move into yellow, and that is where you want to intervene. You don't want to wait till things blow up with your intervention. So it's almost like a continuum. Um, and, we're watchful and we're listening and we're assessing as we go along, and we're going to catch things before they happen. So you, you have the power to redirect them, but coming in at the right time, your timing is critical. So it's kind of like a traffic light, isn't it? It's like green is go. It's calm. Yellow is building, and red is full-blown agitation. So our goal is not to manage red, it's to intervene when the light turns yellow. Does that make sense? And remember that the environment plays a crucial role in shaping behavior. So factors like noise level, lighting levels, all of that can impact a person's comfort and their reactions to various situations. So it's kind of interesting, but a lot of times people with dementia are either understimulated or overstimulated. And what we really are looking for is a balance. They can't be too overstimulated or they'll act out. And if they're too understimulated, they may act out. So, we're really trying to meet people in the middle there and to establish, some types of interventions, those favored activities that I talked about, food, a television show, something that will keep them from being overstimulated or understimulated. Okay, and the way we communicate with them, of course, is going to be critical. We don't want to argue. We don't want to quiz them or test them. When they say things that aren't true, we don't want to correct them. It's easier just to live in their world, just accept that their reality is different than our reality. And so, and it's not just our words that are important, but our tone and our body language, all of that help to cool situations down. So we want to keep our words and our interactions with them simple. And we want to use a very calm tone. We have an excellent handout at Alzheimer's Orange County called Caring Conversations, and it has a lot of these tips that are sort of tried and true. And so if anybody would like to have that, you can let Rachel know and I'll be sure and send it. And watch your words. We want to try to think of a different way of communicating. It's like learning to speak a foreign language when we're dealing with a person we've known for so many years. It's like a different language. The way we've been talking to them and the discourse we've had over the years has got to change due to their disease. And here are just some really simple scripts to illustrate that point. So the when the lady that I was caring for started saying that she hadn't eaten, and I started arguing with her and telling her about all the things she'd eaten, what I really needed to do was just say, let's get you something small. right? Instead of trying to correct her. That's not your house. Instead, we say, tell me about your house. You're fine. Don't worry about it. Instead of, I can see something is bothering you. So these are validating statements that we're making instead of corrective type statements. It's really not even about the words so much as it is about our tone. Okay, I have another, this is another little checklist, just sort of check the routine, simplify the environment, anticipate needs. Sometimes you have to, make changes. We all kind of get up with an agenda every day, and that agenda is not their agenda. And so we may have to adjust our routine and adjust the needs, simplify the environment, build in some rest periods, and maintain hydration and nutrition. That's critical for well-being and good health. So here is a sort of a mnemonic that can help you to provide supportive care. It's called the Calmer method, and it really provides a step-by-step approach to responding to agitation. So C stands for check the cause of the behavior. So as we've been talking about these underlying needs, we need to understand that identifying them is critical. So when we see things changing, we want to pause for a minute and reflect and just try to figure out what is causing the discomfort, whether it's pain, hunger, confusion, fear, and that is step one in the Calmer model. A stands for approach gently. Before entering a tense situation, pause and prepare. Approach slowly and calmly, using very gentle and slow movements to foster safety and trust, ensuring that both you and the person feel secure in the interaction. So this is about just not, walking up behind someone or, making some sudden movements. We want to be intentional about our movements, and we want to do that in a calm and gentle way. L stands for listen and validate emotions. So we're responding to their feelings when we were talking about some of these triggers. Fear was a trigger, confusion was a trigger. So we want to reassure people. We want to respond to people in that way. We want to use empathetic language. I see you're upset. Let me help you. And we just remember, it's not so much about the words, but the connection. If we're holding their hand or if we're sitting beside them on the couch with our arm around them, that's making a connection that is so valuable, so much more valuable than just mere words. So listening and validating. And then M stands for modify the environment. We also talked about this. So sometimes it's a matter of lighting. It's too low, and so they're seeing shadows, and maybe even that might spark or trigger hallucinations. So we want to make sure that things aren't too dark and that they're not too light by on the other extreme. We also want to have kind of a Zen-like environment at home. We don't want a lot of loud, no, don't have TVs on in multiple rooms. Try to control the noise and maybe have some soft music on, something they enjoy. And then we also want to make sure there's not a lot of clutter in the environment because that can spark a lot of behaviors. Remember, I told you about the sorting behavior that my client had, wanting to go through a lot of drawers and things. There was a pile of bills that was sitting out in an obvious place that I had to hide because that would trigger anxiety in her, and she would worry about wanting to pay the bills and have we paid the bills and how much are the bills, so those are all things we can work on and improve. E stands for engage and redirect. And here we're just shifting the focus. And that is that intervention that I've talked about, whether it be, a favorite snack or one of their favorite activities. We know them and we know what they like, and we can think about these things. I mean, you can make a little mental list or even write them down on a post-it, but what are some great things to use at a critical time? And again, it's before the light turns red. It's when the light is yellow that we want to offer them a different focus. And then reflect and reset. So this is, it's sort of like an evaluation. After the behavior has passed, we want to take a minute and we want to learn from what just happened. So, we can kind of think about what worked, what didn't work. Was there some pattern going on? Was there another person present that could have been she or he might have associated them with someone else. So all of these things are part of the evaluation process. And we actually have a wonderful tool kit that we're going to be providing you that will have some of these things in it for you in a handy place. And there's a place where you can actually write down what happened before there was an incident, what happened afterwards, so that you can start to sort of see that there's a pattern sometimes going on of a behavior. And when you identify those patterns, that helps you to formulate your future responses. So this is all a learning. And no one is going to ever be perfect. But hopefully some of the things we've talked about and the tools that we're offering, the handouts will be helpful as well. So yes, we'll work on crafting our helpful responses. We'll validate the feelings behind the behavior. We'll skillfully redirect with those favorite activities, and we will engage with them in a way that provides connectedness. Okay, so let's practice a little bit. All right. Um, let's see, Rachel, how's my time? Oops. We'll do this really quickly.
Yeah, no, and take your time. And if anybody does need to jump off or anything, please feel free to do so. We are recording, but we're good to continue.
Great. So here's some scenarios. Number one, your loved one becomes upset during bathing and says, "Stop, you're trying to hurt me." So what do you do? The first thing I would do is apologize. I'd say, "I'm sorry. I didn't mean to hurt you." What else could we do?
I'd also ask how it hurt. Is it the water temperature? Did I grab you?
Mm-hmm. Although don't give them too many possibilities, right? Because that can be confusing. But yeah. Or maybe just take the warm washcloth and run it across their shoulders and in a conciliatory gesture. Sometimes actions speak louder than words. What about your loved one asks for the fifth time, "When are we leaving?" That those repetitions are, they can be crazy making, right?
You answer them the same way each time, very
Yeah,
calmly.
perfect. That is the perfect response. And as if they never asked, or if they were asking for the first time, right? Your loved one says, "I want to go home," even though they are already home. Let's get underneath what's the unmet need there?
Comfort and security.
Yeah, exactly. So home is not necessarily a physical place, but an emotional state. And they need what?
Comfort and security.
Yeah, they need comfort and security, which you can beautifully supply, right? And while you're reassuring them and validating them and comforting them, you can then do that intervention, that redirection, that distraction, and hopefully that helps. Your loved one says, "You stole my purse."
You can suggest you look for the purse together.
Oh,
Redirect
see,
their feelings.
you guys are so good. Oh my goodness.
Thanks, Rochelle.
Absolutely. That must be so scary. Let me get down on my hands and knees and help you find it, right? Exactly. Okay. All right. So yeah. And here, this slide illustrates some of the times when these things are liable to happen. These are high risk moments, like when you're bathing. I mean, I think everybody knows that most folks with dementia don't like showering. And this is a time when they're going to resist. And so there's a lot, we can do a whole class on bathing. Dressing is usually a matter of just giving them too many options. So instead of, saying, what do you want to wear? You say, do you want to wear the red shirt or the green shirt? Right? And then
It
you're
also
sent
makes sure that the items are comfortable because wool or weight change or sometimes things are pokey or scratchy or tight.
pokey and scratchy is not good. You're absolutely right. In fact, I like the sweatsuits, I mean the slip-on sweats, really comfortable with flannel or flannel, something that doesn't have a lot of zippers or buttons, something that can just be pulled on and pulled off, right? And then what about evening? We want to kind of be prepared for sundowning, right? So
Yeah.
like for me, I knew I needed to change the environment.
Mhm.
Um, right? Okay. So let's see. If there's anything else I want to share with you. I know we need to sort of wrap up now.
I'll just say with regards to medications, if you're on multiple ones or new ones and things change, you should bring your entire list to a pharmacist to have them look over them. Because
Absolutely.
they know more about interactions than the doctors do, because the doctors are specialized on their type of medication.
Yeah, absolutely. What I want to say about this slide is that if you have a very concerning behavior, Uh, maybe it's a sudden change in behavior. So remember, we thought maybe that might be medical. Or if it is, if they're delirious or there's having some kind of a medical, medicines interacting or whatever, that calls for a medical response. Okay. And then as far as medications are concerned, there are only two medications that are approved by the FDA for use in agitation of Alzheimer's patients. And so one is Rexulti, which is an antipsychotic, and the other one was just approved, like these are both just approved, but this other one, I can't even say it. It's Auvelity. It's actually cough syrup with, I think, some codeine. So we don't want to go to medications as the first line of attack. We want to try non-pharmacological interventions first. That's why we talked about all of these strategies today in this presentation, because when we use medications, it increases fall risk. It increases sedation. Um, it can, many of these antipsychotics carry a black box warning. There's increased mortality. So we really only want to use them in extreme situations. And so, any questions about that? Okay. All right. When all else fails, remember that caregiving can be overwhelming and that not every moment has a quick fix. And we talked about that. We can't be perfect. We can't hit the right solution every time. But if you keep your focus on just keeping people safe and give yourself grace during these challenging situations, then you're doing great. And your well-being is essential, so is theirs. None of this is easy, but my hope is that we sorted through some strategies and tools today that can bring you some relief and perhaps reduce, if not prevent, some of the behaviors that you're seeing. Remember, safety first, protecting everyone. If there's a behavioral episode, if the light has turned red, then you want to step back. You don't want to have someone corner you or get in your space. You can and should call 911 in extreme circumstances when you feel safety is compromised. Uh, and that is the acceptable plan of attack. You've tried your interventions, but things aren't working and things are rapidly escalating. You need to get help. Acknowledge that this is hard and it's bound to make people feel frustrated, hurt, and exhausted. So again, this is about giving yourself grace, knowing that you're doing the very best job that you can, and it's enough. It's enough. Don't forget your self-care, recognize your own needs, make sure you get regular breaks, seek supportive connections through friendships or support groups, which I mentioned earlier, and stay aware, communicate the best you can, and then reflect on things that have happened and how you can make them go even smoother next time. Build your plan, identify those triggers, early warning signs, and responses. And the workbook that we're sharing with you will help you to do that. Remember the resources in the community, our helpline, our support groups, all of the offerings from Caregiver Resource Center, as well as Alzheimer's Orange County. And here is our helpline if you want to connect with us. Thank you for being here today. It's my sincere wish that it was helpful for you. And with that, I'll stop our presentation and turn it back over to Rachel.
Wonderful. Thank you so much, Kim. And I think that the information that you shared is really critical and extremely helpful, very validating, and understanding that we're not going to get it right every time, but we're going to do our best and we'll try again and try something new. And I think that you shared some really important information. So as was mentioned, I'll be sending out a number of handouts, the caring conversations, all of those different resources that were discussed. And please, please, please don't hesitate. Connect with Alzheimer's Orange County. We're really blessed that we have a number of organizations that are here to support you all. And the better we work together and the better we can all support each of you. And so please don't hesitate. Reach out to the resources around you. And please take good care of yourselves. Remember, do something nice for yourself today.
Absolutely.
Thank you
Thank
so much,
you.
Kim. Thank
Yeah,
you.
thank you. Thank you. That was
Bye-bye.
really helpful. Okay.
Thank you.
Bye-bye.
Thank
God bless you.
you. Bye.
Bye.
Care, everyone. Have a good afternoon.
Thanks.
Everyone, take care.